You must have been tired and fatigued, but I'll try to maintain my time. So coming to the today's topic, neuraxial analgesia in a parturient with a prior spinal surgery. Is it safe? Is it successful? Is it easy? What are the problems? What to anticipate? This is what I'm going to discuss next 15 minutes. First of all, why discuss this topic? Well, we all know that when we discuss about pregnancy and pregnant patients, it is the airway that is most important. And if you recall the first residency knowledge in anesthesia, the incidence of difficult airway in a non-obstetric population is 1 in 3,000, in obstetric is 1 in 300, in preeclampsia it is 1 in 50, eclampsia and ICU patient is almost 1 in 10. So we have a lady, a pregnant patient with a difficult airway, and this was a very well audited structure saving mothers' lives, where they have found out that anesthesia was one of the third leading cause of maternal mortality in 1950s and 1960s, which became about fifth or sixth leading cause in 1970s and 80s. But with the advent of regional anesthesia, it turned out to be 17 times safer than general anesthesia, and the airway-related issues were almost disappeared. This you should recall the two incidents which happened, two patients in 1948 or 1950, Woolley and Rowe cases who developed permanent paraplegia following spinal anesthetic because of toxic agents, the sterilizing agent that crept into the spinal ampules. And following that, all anesthetics in United Kingdom were general anesthetics, and because of this, more problems, more maternal mortality. But the resurgence of regional took place in 1980s, and since then it turned out to be the safest technique in obstetric patients. And surgical interventions, if you see, 60% of obstetric interventions are emergency surgical interventions, of which about 8 to 10% are category 1 section. That means the decision to delivery interval has to be less than 15 minutes. And quite often 10 to 15% of pregnant patients, they have underlying thrombocytopenia or coagulopathy. So we have a CNB, neuraxial block with spinal pathology, with difficult airway and coagulopathic back, and moreover on top of it we have a patient with a prior spinal intervention. It is quite challenging, quite demanding. Well, the common spinal interventions that we see in obstetric patients are posterior spinal fusion for Cox, still not uncommon in our country, the surgery for kyphoscoliosis, the discectomy and laminectomies, the thicoperitoneal stent for intracranial hypertension, benign intracranial hypertension or idiopathic intracranial hypertension, and sometimes occasional cases of spinal trauma and other surgical interventions in the back. And many a times the patients with pathological back may come without uncorrected patients coming for obstetric intervention. So what are the anesthetic implications? Well, these are the patients who have distorted anatomy. They have the spinous process have been removed because of previous surgeries. The obliteration of and scarring of neuraxial space depending on what type of procedure, whether it's an anterior spinal fusion or a posterior spinal fusion or single level laminectomy or a fenestrated laminectomy or a multiple level laminectomy. It all depends, the pathology depends on the underlying surgical procedure, and the anatomical landmarks are quite poor. Post-surgical, sometimes the patients can have neurological issues, and if you have to give regional, it can be a deterrent factor. And many a times, patients with severe kyphoscoliosis or severe lumbar canal stenosis or backaches, they may have degenerative spines, and they can have residual backache or severe backache even during antenatal period. As such, about 20% of pregnant patients during the antenatal period may have some sort of low back discomfort. So we have more patients with more difficult neuraxial blocks. You end up often giving multiple attempts. Sometimes you have to abandon the procedure because we can't reach the epidural or spinal space. Sometimes because of this prior spinal intervention, you end up with a patchy block or a failed regional. You have an unpredictable local anesthetic spread, either too high or too low, and sometimes you end up with the unintentional wet tap, and often ending up with the PDPH, not responding to your conservative management and how to give an epidural blood patch. Well, let us go step by step. Few diseases which we commonly encounter. First and foremost, of course, is kyphoscoliosis, where earlier 1960s and 70s, the favorite surgical procedure was Harrington rods. Fortunately, Harrington rods are rarity today because the surgical techniques have been refined. The surgeons, they now use multiple hooks, pedicle screws, rods, autologous bone grafts, and titanium interbody cage fusion, which gives better mobility, better fusion, and less scarring in the patient's back. And moreover, majority of the patients, they undergo surgery with anterior approach or lateral approach, so leaving the midline relatively free, and it will be relatively easy. So with all these things, is it still a contraindication? Is neuraxial block a contraindication in a patient with kyphoscoliosis? Well, you need to know certainly that they are not contraindication, but you need to know what type of procedure the patient has undergone. A severe kyphoscoliosis with just a postural correction, it can straighten up and the spine can definitely can become better. So you need to go through the previous X-rays, the latest X-ray. Fluoroscopy of course can be done, but in pregnancy it's a relative contraindication. Well, whenever you consider anesthetic plan in this patient, you need to discuss pro and con with the patients. The ultrasound definitely is a must. It's a boon, especially with the patients with pathological back. But yes, you need to have some sort of a learning curve to utilize its best. Direct the needle towards the convexity side, where the intervertebral vestibules are wider, and select a relatively less curved segment. Subarachnoid space is safe in these patients because it is unscarred, but you may end up sometimes with a high spinal or a very low spinal, and sometimes erratic spread. And if the patient is having a deformed spine, like as I shown earlier in my picture, you may end up with a caudal epidural is a better route. So whether you give a combined spinal epidural or a continuous spinal using spinocath, which is not frequently available in our country, or a spinal anesthetic using sequential needle-through-needle technique or a different space technique, you need to have assess risk versus benefit, or GA could be a safe option. So having understood all these things, you need to plan your anesthetic, and risk versus benefit should be the bottom line when you decide about the anesthetic plan. These three patients, of course, they had relatively uneventful regional procedures, and we have a series of almost about 17 cases of moderate to severe kyphoscoliosis without any problems in the perioperative period or even the long term. We follow up this patient for a long term period, even up to 6 months, because most of these patients are ICU patients, and ICU patients we have a follow up plan. The second common entity is idiopathic intracranial hypertension with a lumboperitoneal shunt. Well, the IIH is nothing but a pseudotumor cerebri. It is quite common in pregnancy. The morbid obesity, PCOD are the risk factors, and the medical management is by acetazolamide, and surgical management often is by repeated dural wet taps to decompress the subarachnoid space by letting out CSF fluid. And if the problem is persisting, if the patient develops visual acuity problem or papilledema, then the surgeons do lumboperitoneal shunt. But when you have a patient with lumboperitoneal shunt, the problem is, if this patient has to come for a cesarean section or a labor epidural, you can't give CSC because the spinal drug which you are giving into the subarachnoid space may escape into the peritoneal space, and you may have a very low block or a very block of a very short duration. And moreover, before you embark upon giving spinal anesthetic to a patient with IIH, you need to know at what level the shunt is placed. So if the patient is having previous notes or X-rays, you see that the position you don't touch, go around 1 or 2 segments below or above that the placement of the shunt. If this patient has epidural is quite safe. We have had 7 cases in our series without any problems because it's a very small incision, just the 2 segment incision, and above or below, it's quite safe procedure. If this patient has an unintentional wet tap, PDPH, is epidural blood patch an option? Yes, there are 2 case reports in the literature where they have had accidental dural puncture while giving epidural to this patient, ended up with severe PDPH, and EVP was given. If you have a patient who has undergone laminectomy, then or patient is having a prolapsed intervertebral disc during pregnancy, how do you do? Like continuous spinal anesthesia or epidural anesthesia or CSCA is quite safe in a patient with prolapsed intervertebral disc, even if the patient is symptomatic. The only thing from your side is make sure that you do a thorough neurological assessment, a detailed assessment, examination of the patient's back. The most important thing, if the patient is having posture, intervertebral disc prolapses, ask the patient which is the protective posture she adopts when the patient, or in which posture she has maximum pain. Majority of the time, this patient, they feel comfortable when the thigh is internally rotated, adducted, and flexed. So try to maintain the same posture once you anesthetize, either for labor or for cesarean section. And you need to be careful when you're putting a wedge under the right hip, because it can cause unrecognized damage under anesthesia. You need to be careful. See that the documentation and discussion of the notes which you have done to the patient are properly done. And of course, spinal is a safe option if the patient has a lumbar laminectomy, because of course spinal process cannot be felt, but you can give a safe subarachnoid block without much of a problem. And one of the good thing is they don't have PDPH, because the epidural space is fused with the ligamentum fluidum. The dura is fused with the ligamentum fluidum. There is epidural space doesn't exist at the level of laminectomy. Well, not infrequently, when you are doing in the PSC clinic, there was one patient where we had impeccable facial anatomy and the torso, but we didn't examine the back, and when the patient, we had counseled extensively for epidural. When she came for epidural, this was the back, von Reckling-Hossen's disease, extensive in the back, and she was having also on the chest, but the face and the hands, nothing much was seen. And these patients, at least about 2 to 3% of these patients, they have spinal tumors, ependymomas are common spinally, and you don't know what sort of things. So documented clearly. In this, of course, this patient had an uneventful epidural and delivery under epidural, but yes, you need to have a clear-cut management plan. Not infrequently, coughs, again, as I said, is very frequent. This bottom patient is a pus that has been aspirated. This lady had ovarian cyst. She was 3 months pregnant antenatally. A laparotomy was planned, and when the laparotomy was planned, the ovaries and uterus, which was about 12 weeks pregnant, was normal, and there was a retroperitoneal bulge. And the surgeon was called in. When the surgeon opened up the retroperitoneal space, there was a psoas abscess, and it was a trickle from the thoracic cox and spine, and we had given epidural to this patient. Fortunately, nothing happened, but yes, in our country, cox of spine is still not uncommon. You do encounter rarely, and your epidural, benign epidural can be blamed. So a thorough preoperative assessment, a history of cough, pleural effusions need to be detected. In this patient, incidentally, we took a chest X-ray post-operatively, and it revealed asymptomatic pleural effusion as well, and it was a cox, pulmonary cox plus cox spine. So examination is very important. Don't hesitate. Have a low threshold to do a chest X-ray, especially in pregnancy, because many a times we are quite hesitant to do an X-ray. The radiation after a chest X-ray is 0.0003 rad, which is insignificant as far as teratogenicity to the fetus is concerned. Many a time you end up with a patient with spinal trauma asking for regional. We have had 2 patients who are paraplegic, permanently paraplegic, required to an extent, but whenever you encounter this patient, quite often they have sensory motor loss, and you don't have to give much of anesthesia, but still you need some of these patients can have autonomic hyperreflexia, and because they are on indwelling catheters, they may have asymptomatic bacteremia or occult urinary tract sepsis, and if you have a bloody tap, it can form an epidural abscess. So you need to be careful that rule out any sepsis in the perineal areas, because systemic infections in the febrile episodes during epidural catheter insertion can be a nidus for infection. So whenever you are anesthetizing a patient with prior spinal intervention, the decision and documentation management plan can be clear. Otherwise, you can't have too many things on a limited track. You need to be very careful what you are doing. So you remember 6 P's. The patient whom you are talking, every patient is a different patient, and you need to tailor the needs depending on the patients, depending on underlying pathology, what procedure the patient has undergone in the past, what problems to anticipate in the perioperative or peripartum period. Put the management plan properly, and see that you deploy a senior experienced personnel who has an integrity in the usage of ultrasound if needed, or even expertise of handling an airway which is compromised. You should remember that neurological deficits in a patient with with prior spinal intervention are rare, but they are not uncommon. And Kane et al., they reported neurological deficit incidence of 3 in 50,000 and 7 in 33,000 series, 2 large series which are reported. So they are not uncommon, but they are definitely safe. So to conclude, I would say that central neuraxial block in a pregnant patient with previous spinal surgery or pathology is not a contraindication, quite safe, quite reliable. The most important bottom line is you need to have risk management strategies in your hospital. The clinical risk management has to be on and should be in place. We devised this obstetric anesthesia dashboard in our hospital, and now entire data of every case which we do is put on this database. There are 43 quality indicators of regional anesthetic practice in our hospital, and wherein we define the parameters in the red zone, the amber and the green, and we always would like to see only greens on this dashboard. That means you are in the acceptable trend. Anything that comes in amber, it's time for you to introspect. That means something is going wrong, the complication rate is increasing, better you review the process. And if it comes in red, then better stop, have a relook, and modify your technique, or change the personnel, or change the hands, or send him for further training. Thank you very much.